Hello, I'm Dr. Bill Gradishar, Professor of Medicine at Northwestern University, and I'm pleased to be offering this YouTube session on trastuzumab deruxtecan, which is an antibody-drug conjugate. And, as we discuss this, let me first start out by telling you that an antibody-drug conjugate is a construct that is created where you attach a targeting antibody to chemotherapy. So it's a kind of a drug that's a combination of different things. A cytotoxic drug like a chemotherapy agent, and then there's a linker that attaches it to an antibody, and it's the antibody that targets a specific abnormality or protein that may be present on a tumor cell. Now, the specific thing we're going to be talking about today is trastuzumab deruxtecan. It has a commercial name that's referred to as Enhertu, which you may remember easier than trastuzumab deruxtecan. And this is a drug that was approved several years ago now, but its use has expanded significantly because it's had such a widespread effect in different stages of breast cancer. When the drug was first being developed, it was a drug that was targeting patients with HER2-positive breast cancer who had developed disease progression following other treatments for HER2-positive breast cancer. And it was demonstrated through a series of clinical trials, a number of trials. They all have the same sort of acronym with another number attached to it depending on the setting where the drug was being evaluated, and these are called the DESTINY trials. So perhaps in talking with one of your physicians, you may hear reference to DESTINY 01 or DESTINY 10 or 12. There are that many different trials. And in the early trials of trastuzumab deruxtecan or Enhertu, it was demonstrated that one, after patients had received many different therapies for HER2-positive metastatic disease, they still responded to Enhertu. So the next questions, of course, would be, could you move it up? Could it be better than what was already available, like TDM1 or Kadcyla? And indeed, it was shown that it was more effective in that setting. And then even more recently, it was shown to be more effective than what we view as the standard first-line therapy, the so-called Cleopatra regimen. So all of the trials I mentioned with the early development of Enhertu were done in patients with HER2-positive breast cancer. Up until that point, we didn't really care about anything that was anything other than HER2-positive by those definitions. But then in the last 5 years or so, we started to look at patients who had HER2-low disease. And these were patients who had some level of expression, but would not have been deemed by the original definitions to be HER2-positive. So there was HER2-low, which could have been 1 plus and 2 plus by special staining that the pathologist did. And even more recently, what we call ultra-low. There's some level of expression, it's extremely low, and we would have never thought of these patients as candidates for HER2-directed therapy. But some of the early trials of Enhertu included patients with HER2-low disease. And it was a fairly striking observation that in these patients, Enhertu had significant activity. And as a result, there were DESTINY trials looking at patients with HER2-low disease as well as ultra-low disease, demonstrating that Enhertu was better than what patients would typically receive, which was chemotherapy. So again, Enhertu is not only utilized now for what we definitely think of as HER2-positive disease, but also HER2-low and ultra-low disease. And again, we depend on the pathologist to help us define the level of expression in any given tumor. The use of this drug has become very widespread. It's very active, and I might add, just as an aside, there are other kinds of cancer that also express HER2, not just breast cancer, and Enhertu has proven to be useful in those settings as well.
Diagnosed with breast cancer? Meet Yerbba, your guide to personalized treatment options. Each option is specifically tailored to the unique characteristics of your tumor. Sign up today at yerbba.com to take control of your breast cancer journey.
But focusing on breast cancer for this discussion, the other part of this is that it is an IV medication. It's something we administer every 3 weeks. And there is a very specific side effect profile that has been demonstrated with the use of the drug. Like any chemotherapy drug, because it is a chemotherapy agent attached to an antibody, you get some of the side effects of chemotherapy, including your blood counts. You can get hair thinning, your blood counts can go down. Some patients can experience nausea. These are often well managed with, say, anti-nausea medicines. The big thing that became apparent early on is in some patients, though very rare, you can get an inflammatory reaction in the lungs. So we call this interstitial lung disease, or ILD. And when the drug first came out several years ago, there was a concern from oncologists that we would be causing more harm than good. But I think as patients and physicians became more sensitive to any changes in patients' respiratory or breathing, we always ask patients how they're doing with respect to breathing. We've gained a great deal of comfort with that, and also the frequency of patients having ILD is very low. So we're still aware of it, we still think about it, we still caution patients to report if they have respiratory symptoms, but this ends up being distinctly unusual. Patients often frequently complain of fatigue. That is one of the side effects that we see with this medication. And of course, the longer you're on it, which is a good sign because you're benefiting if you stay on it for a long time, you're also going to have more of the fatigue that goes along with it. So there's a predictable side effect pattern that we associate with this drug, and its use has become, across the board, much wider than when it was first developed. HER2-positive metastatic disease, HER2-low metastatic disease, and today we're even exploring its use preoperatively in early stage disease, as well as postoperatively in patients who have residual disease following HER2-directed therapy administered preoperatively. So this class of drugs, antibody-drug conjugates, and then specifically Enhertu, has proven to be a significant advance for patients with HER2-positive or HER2-low breast cancer. If you'd like more information about your own specific case or some of the details related to your situation, go to yerbba.com, where you can access the opinions of experts who can comment on your specific situation. I look forward to talking to you in the future about other topics related to breast cancer. Thank you very much.